thermodynamic measurement of the cornea during excimer ablation. Producer Dr. Diego de Ortuita from Aurelius, Germany. The problem of the thermal load of the cornea during refractive surgeries consists of the sequential delivery of a multiplicity of laser pulses that all ablate and heat up a small amount of corneal tissue, with the global process summing up to an integral effect. If corneal tissue is heated up beyond a certain limit, the collagen protein denaturize and their normal function is altered. Denaturation of the corneal collagen protein seems to occur at temperatures higher than about 40 degrees Celsius, where a risk of thermal damage is induced. New laser platforms have small spots that provide a more precise transfer of the planned ablation profile onto the cornea. However, a decrease in the spot size will increase the number of pulses. An increase in the repetition could lead to a much higher temperature. First studies provided analytical expressions for calculation of the thermal load on the cornea in PMMA, and their equivalences. The maximum cumulative thermal load of a treatment increases with the effective local repetition rate of the system. For the corneal ablation we are using an excimer laser with a repetition rate of 750 Hz, and with that device we measured in vivo the temperature changes on the cornea with an infrared camera. First we evaluated the emissivity of the cornea with 0.9 and we show the calibration of the thermographic system. In this study the authors simulated the impact of ablative laser pulses with a flying spot laser beam on corneal temperature. The authors showed that the heat propagation with time across the cornea, and the cooling effect of the cornea with time. Another study shows that thermal load of ablations onto flat PMMA plates declines steadily when the allowed local frequency decreases or when the diameter of the blocked area increases. Conventional laser systems use randomized flying spot sorting algorithms where the temperature increases with the ablation rate. The Intelligent Thermal Effect Control (ITEC) software is a more sophisticated novel alternative to dynamically block small areas around the last spots for a longer time interval, and wider areas around the last spots for a shorter time interval. It dynamically limited the local spot frequency without affecting the laser pulse frequency. The use of an intelligent pulse sorting algorithm ensures a small increase in temperature. The thermal load of a single pulse depends on the energy, reflectivity, the thermal conductivity, the density, and the heat capacity. As the energy increases, the thermal load of the pulse increases as well. The heat propagation is characterized by the heat conductance from warmer to colder areas. This results in lower peak temperature spread over wide areas. We measured the ocular surface temperature of human eyes during refractive surgery with a high-resolution infrared camera. Preoperatively, the temperature of the cornea was about 29 degrees Celsius. The infrared camera was positioned at 66 centimeters from the eye with an angle of observation of 45 degrees. The image shows the temperature distribution of the ocular surface prior to the first pulse. We published the measurement in vivo of 7 myopic eyes with a 500 Hz laser system with the ITEC technology. We acquired a sequence of infrared photographies of an eye with -7 diopters treated with LASIK. The subsequent following 16 images visualize the temperature distribution on the corneal surface related to the time. The time distance between each sequencing images is about 1 second. Temperature scale for each of the images is starting at 29 degrees Celsius, black color, and ranging up to 36 degrees Celsius, bright pink color. The extracted values were sequentially traced from one image to the next and individually for each patient. In this figure we show the mean temperature increase of the optical zone in the 7 myopic patients. All have been measured in vivo during the aspheric profile correction with Excimer. The mean increase was lower than 4 degrees Celsius in all the cases. The most significant rise of the temperature occurs in the first 3 seconds. All measurements showed a slight temperature increase during laser ablation. Noticeably, the temperature rise did not depend on the amount of the refractive correction and the related treatment duration. This film shows the real-time measurement of an ablation with a 750 Hz Excimer laser and measurement taken with a 350 high-frequency infrared camera. The scale shows that the temperature was less than 37 degrees Celsius during the treatment, and the normal temperature of the cornea was preoperatively about 29.5 degrees. The change in corneal surface temperature over time for all treatments revealed a quick rise, which stabilizes within the first seconds of ablation. We analyzed the mean temperature increase of the ocular surface was less than 2 degrees in pink, the maximal temperature. The measured eyes showed a maximal temperature increase of less than 8 degrees, whereas the mean temperature increase was approximately 3 degrees. To determine the temperature rise during treatment, each individual pixel of the thermography camera was analyzed separately. The temperature change of each pixel was compared with the last measurement prior to the beginning of the laser treatment. Then the highest temperature change represented by any of these pixels was defined to be the largest thermal increase. The temperature rise occurred always after 2-3 seconds after the ablation, decreasing after this time. In conclusion, using a sophisticated thermal control algorithm like the ITAC that considers the aspects of the dynamics of the heat propagation in the cornea allows to use a high laser pulse frequency without causing significant thermal load of the cornea. The thermal load measured on the cornea was not critical and did not depend on the ablated volume. It also was not correlated to the amount of corrected diopters.